Hey guys, so today we're talking about general medical condition number 2, which is cancer. Much like we did with heart disease, we will start today by briefly reviewing the organ system that is kind of playing an underlying role in the diagnosis of this medical condition before defining what that condition is, talking about terminology, and then moving forward with diagnosis, treatment, biopsychosocial stuff, et cetera, et cetera. So the underlying organ system for today is going to be the body's immune system. This is our body's defense system, and specifically, this system is responsible for defending the body against what are called antigens or invaders. The system also may help defend the body against mutated or reproducing cells. So these would be like cancerous or precancerous cells versus an antigen or invader might be something like flu virus, coronavirus, something like that. If overactive, the immune system may end up becoming problematic. In this case, we would typically diagnose what's called an autoimmune disorder. And we've actually already talked about one example of this disorder in reviewing type 1 diabetes, where the immune system ends up attacking the insulin producing cells of the pancreas. So, in this case, as in the case of all autoimmune diseases, the immune system is attacking healthy cells versus either invaders or kind of odd, mutated, rapidly reproducing cells. White blood cells are produced through the lymphatic system. I put white blood cells in quotation marks here because it's kind of more of an umbrella term. There are lots of specific cells, but we're not really going to go into detail in this particular class. I also want to point out that while these are blood cells that ultimately travel through the circulatory system, they are ultimately produced in a separate system, which is the lymphatic system. As you guys will see in the graphic on the right-hand side of the screen, the lymphatic system looks very similarly to the circulatory system or even the nervous system, for that matter. It's kind of these various branching parts that cover really the entirety of our body, reaching into our extremities. One difference I will say between the lymphatic system and the circulatory or nervous system is that the lymphatic system is more concentrated around particular lymph nodes and glands that are more responsible for various functions relating to the immune system. Examples would be different areas that are responsible for producing cells. Other areas are responsible for kind of removing and disposing of old cells. And so white blood cells, which are the cells that are responsible for really kind of seeking out and destroying those antigens or those mutated, excessively reproducing cells, while they do their job via the circulatory system, they are produced and disposed of utilizing the lymphatic system. It's also the arrival of these white blood cells that contribute to inflammation. So if you've ever kind of cut yourself and you've noticed that like over time, like half hour passes, an hour passes, that area gets kind of red and puffy, or like if you get stung by a bug, that area is kind of red and puffy, that is inflammation. And that inflammation is a result of white blood cells kind of like arriving on the scene and helping to sterilize the area, address any antigens that may have gotten in through that injury to keep us healthy. Um, White blood cells are also responsible for the inflammation that happens through the course of inflammatory diseases like cardiovascular disease. The strength of one's immune system comes from a combination of genetics, We also get a good bit of our kind of baseline immunity via breast milk if we were breastfed as infants. This isn't to say that if a baby is not breastfed for any variety of reasons that they're like screwed. Breast milk is just one way to establish an immune system, but there are other ways as well. Regardless of whether a baby's been breastfed or not, it's inheriting genetics from its parents. Vaccinations are also a way to promote a healthy immune system. The environment is also a way to promote a healthy immune system, just exposure to various antigens helps the immune system to practice, so to speak, and develop antibodies so that it's better prepared for more serious invaders down the line. So, for example, research shows that kids who grow up in homes with dogs have up to a 70% stronger immune system than kids who grow up in homes without dogs. Again, not to say that kids who grow up in homes without dogs are screwed, much like the whole breast milk thing. It's just kind of one factor and one example as to how the environment can introduce antigens and kind of help to train up that immune system. So, what is cancer? Cancer ultimately is a set of diseases in which abnormal body cells multiply and spread uncontrollably. So, going back to this slide, that would fall under the mutated and reproducing cell category. So, these aren't things that invaded the body, these are just strange cells that happen to also be reproductively gifted, and so they spread. Collectively, cancer accounts for the second leading cause in cause of death, cause of death in the United States. And it, much like cardiovascular disease, is an umbrella term. There are many different specific types of diagnoses that exist under that general label. So we'll talk about some of those terms here on the next slide. In general, these abnormal cells form a tissue mass, which is typically referred to as a tumor. Not all tumors, though, are cancerous. Some are benign, in which case these tumors remain localized, so they remain in the spot where they grew and they do not pose a health threat. However, those tumors that are malignant or cancerous are the tissue masses that regenerate cells that ultimately aren't responsive to the body's regulation of growth and division, meaning that the immune system is attempting to regulate and kind of halt the growth of these tissue masses, but is not successful, basically, in doing so. Malignant cells also have the ability to migrate to attack and destroy other tissues, and we will use the term metastasis to refer to this. So when a cancer is metastasized, that basically means that it is spread from its origin point elsewhere. So a cancer may metastasize from the breast, for instance, to the brain, potentially. Again, cancer is not one disease, but a related set of more than 100 related diseases, most of which are classified into one of four types. Carcinomas attack the epithelial cells, which line the inner and outer surfaces of the body. Examples include breast cancer, prostate cancer, lung cancer, and skin cancer. Sarcomas are malignancies in the bones, muscle, and cartilage, so these are very structural cancers. Lymphomas are lymphatic cancers. These are going to be either Hodgkin's lymphoma or non-Hodgkin's lymphoma. And then leukemia is going to be a set of cancers that attack the blood and the blood-forming tissues, such as the bone marrow. In terms of who demographically is more susceptible to cancer, men are more likely to develop cancer than women. About half of men over the course of their life develop cancer compared to about a third of women. Women, however, are more likely to develop cancer before the age of 60. So a lot of this has to do with the fact that as men get older, their likelihood of being diagnosed with prostate cancer goes up dramatically. And so if we're looking at the lifespan approach, men over the course of their life, because of that age-related prostate cancer, are diagnosed with cancer much more often, even though we're more likely to see things like lung cancers or breast cancers potentially from women at a younger age. Lung cancer is going to be the top culprit for both genders, followed by prostate cancer and breast cancer as number 2 for men and women, respectively. The older people become, the greater the chance of developing or dying by cancer. But I will also point out that cancer is also the second leading cause of death among children ages 1 to 14. One of the reasons the cancer ranks so highly as a cause of death for young people is because not many things these days cause death frequently to kids. And so anything that's killing really any number of kids is going to rank highly. But that doesn't mean that objectively it's a large number of children who are dying, whereas large numbers of older adults who do end up dying by cancer. Black Americans have the highest overall cancer incidence. This is primarily because of high rates of lung and prostate cancer among African American men. This group is also more likely to die of cancer once diagnosed. Like the other diseases that we've talked about, and we'll talk about, SES, education, attitudes, and poverty-related access to healthcare are some of the environmental factors that unfortunately drive this trend. More behavioral controllable risk factors include things like tobacco use, diet and alcohol use, physical activity, weight status, family history, environmental hazards, and stress and immunocompetence. We'll talk about all of these in greater detail with the exception of stress and immunocompetence. We've already talked about stress and its impact on the immune system, so I won't rehash that. Just to reiterate and kind of summarize, stress can depress the immune system, specifically though chronic stress. So acute stress is not going to have a significant impact on the immune system. Chronic stress, however, will. And remember that stress isn't causing cancer. It is instead depressing the immune system, limiting the immune system's ability to do its job, which is increasing the likelihood that a cancerous cell will be able to mutate and spread. So let's get on to the first of these, which is going to be tobacco use. We covered tobacco use broadly speaking in talking about the behavior of substance use. To reiterate, tobacco use is the most preventable cause of death in our society, contributing to about 20% of overall deaths. It being a preventable cause of death, of course, means that these are unnecessary deaths that could be prevented with behavior change. Tobacco is the single most lethal carcinogen in the United States. We'll talk more about some other environmental carcinogens later on in this lecture, though we won't talk about all of them. We'll talk about some of the big ones. Also, just to remind you again from our discussion of substance use, that tobacco takes its effect as a carcinogen not just via direct use, that is, if a person is vaping or smoking or chewing, but it also takes its effect via secondhand smoke as well. Many teenagers, approximately 40%, try smoking and report regular use. About 10% end up smoking daily. As we've already discussed as well, this is largely due to peer influence and pro-smoking media. Relevant cancers that may be impacted by tobacco use include cancers of the lungs, mouth, stomach, larynx, which is our voice box, esophagus, pancreas, uterus, cervix, kidney, and bladder. About 20% of lung cancer patients who previously smoked continue to do so, which really underscores how addictive this particular drug is. I mean, you use it, you literally get lung cancer, and you continue to smoke despite that diagnosis. And unsurprisingly, continuing to smoke through a lung cancer diagnosis increases the risk of recurrence and additional tumors. As far as diet and alcohol goes, I've kind of lumped these two together as, things a person would consume. These are the only things that rival tobacco as a cause of cancer, diet specifically accounting for nearly the same number of deaths each year, about a third of all cancer deaths. Dietary factors that impact cancer risk are the types of food that are consumed, how the food is prepared, the portion size, caloric balance, and ultimately whether a diet is balanced or not. More specifically, cancers are going to be most common among those who are chronically malnourished, or on the other end of that dimension, people who are consuming very high fat, high caloric diets, people who commonly consume certain food additives, specifically nitrates that are very commonly found in like deli lunch meats and other foods with preservatives. And then alcohol use is also going to be another dietary piece in there. Excessive alcohol use, particularly among smokers, uniformly increases cancer risk for both respiratory and digestive cancers, in addition to breast, colorectal, and liver cancer. To discourage cancer risk, it's recommended that patients reduce their intake of foods high in saturated fat and sugar, consume more of a plant-based diet, not a vegetarian diet. Remember, there's a distinction between plant-based and vegetarian. Limit red meat and particularly processed meat that is likely to be high in nitrates. Limit alcohol consumption, not necessarily cut it out, but limit it to potentially like a drink a day, maybe not even every day, and reduce overall salt intake as well. As far as physical activity and weight status go, research indicates that a lack of physical activity can be a risk factor for certain cancers. Interestingly enough, though, unlike heart disease, work-related and recreational physical activity both have a protective effect against cancer. So you'll recall from our discussion of heart diseases that it's recommended a person seek out physical activity and movement in their leisure time, not through work, because work carries that added stress. And so, if you're getting in a ton of movement, but you're really stressed out at work while you're doing it, it's kind of like those two things cancel each other out. But as far as cancer goes, it seems that any kind of movement is a good thing, whether it's at work or in one's leisure time. In addition, research also suggests that walking may be as effective in protecting against cancer as more strenuous forms of exercise. So again, that can be something really important to kind of keep in the back of your mind as a provider, that, if you're working with a patient who, whether they're overweight, obese or not, a patient who is kind of adverse to physical exercise, that being able to talk about something as simple as walking as being effective versus, needing to be training for a marathon, that can be a helpful way to kind of diminish the barrier to exercise. So that can be a helpful tip combined with some of the more general tips we talked about relating to exercise in our previous lecture. Obesity specifically increases the risk of cancer, so that's why putting on excess weight, and then on the opposite end of things, the importance of physical activity and preventing excess weight gain is so important when it comes to cancer. Specifically, obesity increases the risk of endometrial cancers that may impact the uterine lining, colon cancer, kidney cancer, cancer of the esophagus, pancreas, ovaries, and gallbladder. One of the reasons that obesity impacts cancer is because obesity ends up impacting both a person's secretion of sex hormones and insulin. As we covered in our previous chapter on diabetes, you'll recall that fat cells can decrease the sensitivity of insulin to target cells, which can be damaging. Beyond that, fat cells also secrete larger amounts of estrogen. And because some cancers are hormone fed, certain types of breast cancers are hormone fed, endometrial and colon cancers may also be hormone fed. So those are some of the pathways by which obesity may impact cancer diagnosis. Family history is also important. Only a small percentage of all breast cancers are inherited, and this really kind of goes across cancer. We're going to focus a little bit more so on breast cancer as far as genetics and family history goes, just because, frankly speaking, this is a very popular cancer. If you think about all of the cancers and all of the months that get dedicated to cancers and all of the walks and fundraising, breast cancer is definitely a very popular one. It's one that's in the limelight. And so as far as research goes into genetics and family history and better understanding cancers, typically the popular cancers end up being the ones that are cracked first compared to things like non-Hodgkin's lymphoma. So we know a lot more about breast cancer, basically. So we're going to talk a little bit more about breast cancer specifically as far as family history goes, but much of these findings do kind of generalize. So only a small percentage of breast cancers are inherited, and this kind of goes really with a lot of the other cancers as well. that even if there is a family history there, there is a difference between genetic factors and non-genetic factors. So if a family history is present, like mom, grandmother, sisters, aunts have breast cancers, this could be due to genetic reasons or non-genetic reasons. Genetic reasons would be something like a genetic mutation that is physically inherited person to person that is causing the cancer. But when there's a positive family history, it's also important to note that that could be due to non-genetic reasons. For instance, obesity may run in the family. And again, this could be genetically based, or obesity is very behavioral in nature. You know, we've talked about that in this class, that it's common if you're surrounded by people who are engaging in one particular type of health behavior or health risk behavior, it's more likely that other people are going to follow suit. So obesity can really be a non-genetic factor as well. People who go through menarche or their first menstruation at a younger age are more likely to be diagnosed with breast cancer. That can just be a non-genetic thing that kind of runs in families as well. Lack of exercise can be non-genetic in nature, as can tendencies to smoke or follow a poor diet. Use of oral contraceptives can increase cancer risk as well. In a nutshell, some of the reasons behind a younger menstruation age and the oral contraceptive piece are that basically menstruating at a younger age, or in particular taking a hormone-based oral contraceptive, is introducing hormones into the body at a younger age. And as we've already covered, hormones, particularly estrogens, can play a role in not all breast cancers, but specifically those hormone-fed breast cancers. So that's kind of the path in terms of how those factors take their effect. Radiation exposure, which could come in the form of ironically getting mammograms at a younger age because of a positive family history. And then alcohol use can also be a non-genetic factor as well. Only about a third of the women diagnosed with breast cancer each year have a family history of the disease. And again, this is family history, which could be a combination of non-genetic factors in addition to genetic factors as well. Beyond the non-genetic pieces, there are genetic mutations that can be inherited. Breast cancer, in addition to ovarian cancer, prostate cancer, pancreatic, laryngeal, and skin cancer are all cancers that are linked to genes that can be inherited. Two of the big ones are the BRCA1 and 2 genes, and those are genes that we will be talking about a bit more in this class again, just because of their notoriety. BRCA stands for breast cancer, so breast cancer 1, breast cancer 2 genes. Something that's important to realize about inheriting cancer genes, so to speak, or for that matter, inheriting any type of gene, whether it's an obesity gene or a cancer gene, is that this person isn't inheriting a new gene that other people don't have. Rather, what they're inheriting is a genetic mutation. And so this gene is mutated and therefore functioning differently in the person who has the mutation relative to the person who doesn't have the mutation. So how the BRCA1 and 2 genes work, for instance, is they contribute to the body's ability to detect and fight off abnormal, mutated, reproducing, possibly cancerous cells. Fortunately, we get a copy of these BRCA1 and 2 genes from both our biological mother and father. And so even if a person inherits a mutated version of this gene from one parent, they've got the healthy version from the other parent. But what happens over time is that these genes kind of lose their efficacy as a person gets older. And so the person kind of, as they age, loses the protection of that healthy gene and is really kind of left with that mutated gene that doesn't do its job quite as well, which increases the likelihood of a cancer that previously, you know, with 2 healthy genes would have been isolated and addressed early. It increases the likelihood of that cell not being caught and left to reproduce. So again, big takeaway is that these are mutated versions of healthy genes that are inherited, not unique genes that other people don't have. Other takeaway from this slide is that family history boils down to genetic and non-genetic factors. So it is important to distinguish someone who has a BRCA1 mutation, for instance, from someone who simply has a family history, because they are different. Finally, environmental hazards. In addition to tobacco, there are several carcinogens that pose a cancer hazard. There are many things, including things like asbestos, but two of the big ones are going to be air pollution and UV, or ultraviolet radiation. Air pollution may increase the risk of lung cancer as much as 50%. This can be due to construction and smog. This can also be associated with secondhand smoke. Ultraviolet radiation damages DNA, causing about 90% of skin cancers, which includes melanoma. At the end of the day, this radiation may be impacted by the ozone thinning, but behaviorally speaking, can also be impacted by an individual's decision to engage in sun tanning behaviors, not using sunscreens, which can increase the risk of sunburn and eventual melanoma. Comparative optimism may explain some of these health risk behaviors. You may recall this term from previous lecture. Just to reiterate, comparative optimism is going to be when a person acknowledges that, oh yeah, like you can definitely get skin cancer from sun tanning, from not using sunscreen, but like that's going to happen to other people. That's not going to happen to me. As far as treatment goes, early diagnosis is key in that it can prevent death and reduce overall treatment time. Many people, however, do not perform self-examinations. Surprise, surprise, that's kind of a theme in this class, people's tendencies to not do what is healthiest for them. People also don't always follow recommended screening schedules for the cancers that we have screening schedules for, which are things like breast, colon, rectal, and cervical cancers. Some of the things that factor into this are things like comparative optimism, perceived risk and vulnerability. A person doesn't think it's basically going to happen to them, or doesn't think there's a risk that they are going to get sick. And so as a consequence, they're less likely to comply and screen. As far as family history goes, it's definitely helpful to identify people with significant positive family histories and refer those folks for genetic screenings. Genetic screening would be the process of determining whether or not there is a genetic mutation underlying that family history or not. Again, remembering that not all family histories are associated with genetic mutations, but that genetic mutations come with an added risk on top of family history, because we know for sure that the cancer is coming from this, versus a family history could be any number of things, and theoretically you could negate a positive family history with healthy behavioral change if what was really driving the family history was kind of community level health risk behavior. At the end of the day, genetic testing is done via blood tests that are done to detect whether or not these genetic mutations are present. So this is what's done, for instance, in the case of screening for the BRCA1 and 2 mutations. I do want to point out that psychosocially, this can be a very complicated process. As getting a positive result is a good thing. You know, it means that you know more information about your future and you know of treatments that are available, but it can also be very stressful information to have. It's very rare that a person gets this kind of information about their future. And this can be just very stressful for patients. And so I like to tell students about that, because typically as a provider, if you've got this tool that is going to help a patient, that's a good thing. You know, I've got this tool that's going to give you more information and help you make health decisions. Awesome. And at the end of the day, it is awesome, but it also carries psychosocial stress with it. So it's important for providers to be aware of the multitude of pieces going on for people who are going through these tests, whether they are for the BRCA genetic mutation or other genetic mutations. Some specific examples relating to the BRCA mutation are that, you know, if you find out you have this mutation, basically at the end of the day, patients have two choices. They can either go through surveillance, where they undergo mammograms, MRIs, ultrasounds, multiple times a year to make sure that they don't have cancer, which can just be really stressful going to a hospital regularly with cancer patients to get tested, constantly waiting for results. Or a person can pursue surgery where they would have their breasts removed basically preemptively or their ovaries removed preemptively because these are organs that are not necessary for life. And so you could easily just remove them and decrease any likelihood of getting cancer. Of course, that's easier said than done because these are aesthetic organs. These are organs that relate to a person's ability to reproduce. It's also very distressing to think about removing tissue that is technically healthy right now. This could also impact a person's relationships if you're dealing with a young woman who has been diagnosed before she has partnered or had children. If those are things she's wanting to do, that could put immense stress on that situation, as is just this idea of kind of knowing your own future. I'd recommend pausing at this point to read Reproductive Issues for Women with BRCA Mutations to kind of explore some of these psychosocial elements further. Treatment options for cancers, genetic or otherwise, include surgery, as well as some other options like radiation, chemotherapy, and immunotherapy, which we'll talk about here in a moment. Surgery is going to be the oldest form of cancer treatment and generally offers the greatest chance for a cure to most types of cancer. About 60% of patients opt for surgery directed at one or more of the following goals. Diagnostic surgery, such as a biopsy, is aimed at obtaining a tissue sample for a lab test in order to confirm diagnosis. So at this point, it might be like we detected a mass in your breast. We don't know if it's benign or malignant, and so we're going to use a needle to get a small sample to figure out what's going on and whether or not we need to go further in terms of treatment. Preventative surgery would be removing non-malignant growths or healthy organs in the case of genetic cancers. So this might be the removal of, like I said, a benign mass, or as in the instances I covered on the previous slide, removing things like healthy breasts, ovaries, things of that nature to prevent a genetic cancer, hence the name preventative. A staging surgery is kind of like a diagnostic surgery. It's not really removing anything per se, but we're kind of going in to determine the extent of the disease to set up a curative surgery down the line. Curative surgery is the removal of a malignant tumor when it is localized, and there's hope of removing it all with clean margins. So this means the cancer is limited to this area. It's got nice lines to it. We're going to be able to go in and get it all. Curative surgeries typically aren't used as much in surgeries in tumors that don't have clean lines or tumors that have metastasized and have spread. It's just not as efficacious to go in those types of situations. Fortunately, there are other approaches that we'll review in the coming slides, and sometimes these treatment options are combined. So chemo or radiation might be used to shrink a tumor before kind of going in with a curative surgical approach. Finally, we've got restorative or reconstructive surgery, and this is actually a type of surgery that would be done by a completely different surgeon. So up until this point, the surgery would be done by a surgeon who is specialized in dealing with that particular area, whether that be a general surgeon or a breast surgeon. The restorative or reconstructive surgery, however, would be done by a plastic surgeon. And the aim of this approach would be to restore a person's appearance or functionality. So for example, breast reconstruction might be done following a mastectomy, whether the mastectomy was preventative or not. Bone or joint replacements could also be utilized following bone cancer. Another treatment option is radiation. This is when a high dose of X-rays are delivered to cancerous tumors to kill or damage them so that they cannot grow unchecked and spread or metastasize. Some normal cells typically end up being impacted by the radiation as well because the radiation is not so specific that it hits just the cancer and nothing else. Most of these normal healthy cells, however, appear to repair themselves and recover fully from the effects of treatment. But it is this damage to healthy cells that, for instance, can cause hair loss. It's because those healthy hair follicles are being damaged by the radiation process. Radiation only impacts the tumor and the surrounding area. This is different than chemotherapy, which has more of a global effect. This is the primary cancer treatment that's pursued by more than 50% of cancer patients. This typically ends up either setting up surgery or being a follow-up to surgery. Even if a curative approach is used initially, radiation may be used to just make sure that there weren't a few cells kind of left behind. Because, it is kind of how cancer goes, that, it starts out as a single mutated cell that is really good at reproducing and spreading. And so it's critical to get every single one. And so, again, sometimes these approaches will be used to set up a surgery, sometimes they'll be used to follow a surgery. Side effects include fatigue, loss of appetite, skin rashes, permanent hair loss, potentially if those follicles are seriously damaged, or loss of white blood cells. Chemotherapy is frequently compared with radiation in that they're both non-surgical approaches, but they are different. Radiation is using X-rays, chemotherapy is using medicine. Surgery and radiation destroy cancer cells in a specific area. Chemotherapy, on the other hand, can destroy cells that have metastasized because it's administered through the blood. So it's impacting the entire body versus just an area. And so again, if a person has metastasis, then chemotherapy is probably going to be the best approach compared with radiation or surgery. It may be used to cure cancer depending on the type and the stage. It can slow the growth of cancer and also relieve some of the symptoms as well. Immunotherapy is a new form of chemotherapy, and this is medication that is aimed at enhancing the immune system to selectively target cancer cells versus chemically destroying cancer. So, chemotherapy is basically using chemicals to destroy cells, including cancer cells, versus immunotherapy is aimed at kind of bolstering the person's immune system so that their immune system can kill the cancer cells themselves. Cancer drugs can also damage healthy cells, including those in the hair follicles, which, as I mentioned before, lead to hair loss. Nausea and fatigue can be common side effects as well. There are alternative treatments. These are typically referred to as complementary and alternative treatments. We will review these later on in the semester. I highlight complementary because when it comes to something like cancer, which has very strong biological kind of pieces to it, it is important to follow what the science says as far as treatment, which is going to be the stuff I reviewed on the previous slide. That being said, complementary and alternative treatments may be helpful in terms of relieving symptoms or easing pain, improving quality of life. And so these pieces may be added on, but they should not be used standalone versus something like a surgery for cancer. In terms of coping with cancer, it is common for folks with cancer to exhibit higher levels of anxiety, anger, hostility, and depression relative to folks without cancer. Older people may be less distressed, and this may just have to do with the fact that cancer is more normalized at that age, and so it's less of a surprise, versus younger folks may be kind of hit harder with the emotional repercussions. This is an area of intervention, particularly as survival rates have increased. So what this basically means is that, particularly again among young folks who may be hit really hard with cancer diagnosis, we've gotten a lot better at treating cancer and promoting survival. And so this basically leaves people with the emotional kind of pieces left over. And so that's kind of the remaining quality of life piece that we can kind of address as professionals. So for example, we've got a young person, let's say a person with a breast cancer. They are treated successfully, cancer is in remission, but frequently, even in this case, things like fear, stress, and uncertainty don't go away. Someone who opted for a lumpectomy, which is where just the cancerous lump is removed versus the entire breast or both breasts, may feel that even though they're cancer free, that they're kind of waiting for the other shoe to drop. And so we've successfully treated cancer, we've promoted survival, but we've still got this very evident kind of psychological piece left over. And so this is kind of really an area of intervention for mental health professionals, and just an area to be cognizant of for surgeons or people working more in a hospital medical type of setting, to just be looking for this stuff and referring folks out. A person's mindset seems to be a huge predictor of mental health and well-being. For example, pre-surgery expectation seems to be a significant predictor of post-surgery fatigue, pain, and nausea. So if a person's very hopeful going into surgery, they're more likely to recover well, be less tired, have more energy, experience less pain, less nausea as well. Emotion-focused coping becomes very important as far as cancer goes. You'll recall this term from our previous chapter where we talked about coping in general with stress. Emotion-focused coping, again, is that process of kind of dealing with one's emotions, and not repressing emotions, but kind of experiencing them, whether they're positive or negative in nature. And this can be very beneficial as far as cancer goes, typically because the problem-focused element of coping is relatively short-lived. You know, you sit down with your doctor, you figure out your treatment options, you make your decisions, and then you're kind of done. You've solved the problem, so to speak. You've done what you needed to do, and now all you have to do is follow through with treatment. And so at that point, the remaining piece is the emotional piece, much as I kind of alluded to on the previous slide. Even when we've successfully treated, the emotional piece is the remaining piece. And so emotion focused coping becomes tremendously important as far as cancer goes. Emotional regulation, for that matter, is critical to adjusting to any traumatic event, whether that is a car crash or a cancer diagnosis. So it's very important to be aware of this as a provider, whether you're a healthcare provider or a mental health care provider. We'll sometimes use the term emotional intelligence, which is sometimes abbreviated as EI or EQ, as like the emotional alternative to intelligence, the intelligence quotient, or IQ. EQ is someone's ability to perceive, understand, express, and regulate emotions accurately. And unsurprisingly, people with high EQs typically experience less anxiety, depression, and overall distress. So, folks who are able to understand their own emotions, express their own emotions, and kind of perceive emotional changes in others typically experience less clinical diagnostic anxiety, depressive disorders, distress in general. Optimism is associated with active, engaged coping, less psychological distress at the time of diagnosis. It may also lead to a difficult time adjusting to disappointing outcomes. We've talked about optimism before, and in general, optimism beats pessimism every day of the week. The one thing people will bring up sometimes is the idea of like, well, isn't realism better? Like, what if a person gets their hopes up and, you know, their chance of survival is really low and they're just going to get crushed? Yes, that can be a possible consequence of optimism, but at the end of the day, I would still much rather have someone who is unrealistically optimistic compared to someone who is unrealistically pessimistic. But yes, kind of the notion of someone being crushed by a disappointing outcome is the potential risk to be concerned with, but I would recommend that you cross that bridge when you come to it, and just that the benefits of optimism much outweigh the consequences. So again, I would take the unrealistic optimist any day of the week. This leads us into cancer and masculinity, in that women are socialized much more to have higher levels of emotional intelligence than men are. Much of this has to do with socialized masculinity, this gender role conflict that, like, I'm feeling emotions, but I'm not really supposed to feel emotions. What do I do with this? And some of this has to do with gender linked personality characteristics, like men having a greater tendency to exhibit anger, irritability, even hostility, and those characteristics being associated with poor cancer outcomes. Men have a greater tendency to perceive cancer as a threat to their masculinity. So cancer is making me weak, it's threatening me, and as a consequence, men actually are more likely to experience worse symptoms as a consequence of this. This includes poor sexual, urinary, and bowel functioning. Um, in the context of like a prostate cancer. These men are also less likely to engage in emotion-focused coping. So there are very real physical consequences to not engaging in emotion-focused coping when it's warranted. Some of the reasons for this, in addition to the socialization, the gender role conflict, the personality characteristics, are that men in general have fewer male cancer role models. It's less likely to see these characters represented in the media. It's less likely that you're going to see these guys speaking up on social media as kind of faces for cancer. It's less likely that you're going to see groups organized around these types of cancers in patients as well. Men are also less likely to follow wait and watch prescriptions, meaning if you tell a male patient that, there is a mass in your testy that looks suspicious, can please continue to palpate it, every week for the next few months and come back in 2 months and we'll take another look. Men are more likely to just kind of ignore it. Ignorance is bliss, not follow through. And as we've already established, early detection is key for promoting survival, decreasing treatment time. And so it's more likely that if there's a problem, it's going to get worse. And then if we combine that with a later stage diagnosis, a lesser tendency to engage in emotion focused coping, now we're really dealing with a worse prognosis as a complication of all of these factors. Other kind of more psychosocial pieces to be cognizant of as far as treatment goes are knowledge, control, and social support. These are familiar concepts that we've talked about, at other stages of the semester. Knowledge is powerful. It typically helps people to know what's going on. And so it's helpful as a provider to be able to sit down and answer questions. It's for this reason, too, that I like to educate students in this class a little bit about like some of the background in terms of organ systems, some of the terms, even though you guys broadly speaking are either pursuing healthcare or mental health care. And those of you in mental health care, like you're not going to be doing surgery, you're not going to be doing blood tests. You don't need to know the nitty gritty of how the immune system works. But because the physician or the surgeon might only be meeting with the patient for 5, 10, 15 minutes, the patient may be panicked, kind of shell shock, deer in the headlights kind of look, might not know that they need to go to those meetings with a list of questions. They might leave really confused. And because as a mental health professional, you're meeting with them, weekly, every other week for an hour at a time, you're in a position to better be able to answer some of those questions and help to soothe patients with knowledge and information. And so it's important, whatever side of the equation you're coming down on, physical versus mental health, to know about what's happening on the other side, to be able to connect the dots and kind of treat patients more holistically. Fortunately, in addition to getting information from providers, the internet these days provides us with, while you can definitely get some shoddy information out there, you can get some good information as well. And that information comes side by side with social support as well, which is great, in another day and age, just, as recently as several decades ago. I mean, you could be diagnosed with something relatively rare and live in a small town and feel completely alone. But these days, you can have pretty much anything and find a support source, support group online, and feel better and less isolated. So knowledge is important, social support is important, whether it's online or in person. Control is important. We've talked about perceived control before and how at the end of the day, it's a good thing, even if it's just the perception of control versus legitimate control over what's going on. And that really comes into play with cancer because so much of it is outside of a person's control. Like you've got control over your health behaviors, But other than that, you're kind of in the hands of providers, and depending on what type of cancer you have, the treatment outcomes may be very different. And so having control and using that control wherever you can is important, and providing as much control as possible to patients is very important. So something as simple as letting patients decorate their hospital rooms, particularly if they're going to be there for a long period of time, or even like choosing a meal are really good ways to promote well-being. It's actually for this reason that more hospitals are moving away from like meatloaf is for dinner and that's it, to providing patients more of like a choice, like a kitchen that makes several things, and it's not like a full menu, but you at least get to choose from 3 or 4 options what you want to eat for breakfast, lunch, or dinner. So those are some psychosocial pieces to be mindful of, again, regardless of whether you're more physical or mental health in your focus. Finally, I want to round out today's talk with some cognitive behavioral interventions, so some approaches that a mental health care provider might use if intervening. One of which is something called mindfulness-based stress reduction. We've touched on this earlier in terms of talking about coping. This basically entails using a variety of meditation and breathing techniques to help people manage stress. These are things people can pursue through mental health treatment, but you can, of course, also pursue meditation and things like that through like online meditation or yoga classes as well. Exercise, of course, great general intervention. We've established that for cancer, any movement is good. Dietary changes are, of course, also helpful. And again, those are things that mental or physical health professionals can help kind of advise with. Guided imagery is a more specific approach that may be utilized by a mental health professional. This basically entails replacing negative, scary images with more strong positive ones to promote a sense of optimism and help people enter into treatment with a healthier mindset. We've already established that, the mindset that you have going into surgery is the mindset you're going to have leaving surgery. So someone who's optimistic is going to leave healthier and with better outcomes compared to someone who's pessimistic. And so guided imagery is kind of this meditative process that entails helping a person connect with their senses and helping a person to paint a picture of an optimistic outcome. So if you've got a patient who's really worried that surgery is not going to work and they're going to die on the table, it'd be helpful to, in sessions leading up to surgery, help a person visualize and imagine what it would be like to have a good outcome, and to do that again and again and again, and to help a person imagine what that would feel like, look like, sounds, tastes, even smells that would be associated with that outcome, and to just kind of review that again and again and again and again. And guided imagery is an interesting approach. It's a very general approach that can really be used across the board. It can be used in health situations. I've also seen it used in like sports psychology kinds of situations too, where you may have a sports psychologist working with an athlete on a particular skill like shooting free throws, and guided imagery might entail like mental practice of getting out on the court and making the shot again and again and again, and mentally kind of practicing and mentally envisioning that outcome. And whether it's with sports or with health, this approach has been associated with greater likelihood of being relaxed and confident when really in that particular situation. A final kind of interesting approach that I'll share with you guys is one that has its basis in kind of psychology, but it's really an approach that, anyone could basically use. It has to do with systematic desensitization and stimulus control, which sounds really fancy, but it's basically a way of saying that we are taking the focal point of an unwanted symptom and shifting it. So frequently, things like chemotherapy, for instance, come with nausea. Um, Chemo makes people nauseous. That's just a side effect. That's just the way it is. But unfortunately, for people getting chemo regularly, the nausea can be so frequent and intense that people may start developing cued nausea, meaning that they haven't even gotten the chemo yet. They're just driving up to the hospital, but the site of the hospital is so associated with chemotherapy that the person ends up getting sick upon arrival. So The problem's basically just been made worse by the fact that now the person's mind has generalized the nausea beyond the chemotherapy to the hospital in general. And so now the whole hospital makes them sick, whether they're there for chemotherapy or another appointment. This isn't good. This is an undesirable outcome. And so what we're going to do in this situation is we're going to shift the focus of the nausea. One of the ways to do this is to provide a person with another piece of sensory input to attach that association to. So one such commonly used approach is to give chemo patients popsicles to eat while getting their treatment so that they'll associate the nausea with the popsicle. One of the reasons this works is because nausea is a gastrointestinal symptom, or more commonly to associate it with something that we've eaten, particularly if we're eating right now, since that's typically what causes nausea. And so if you're eating something and you're feeling sick, your brain is going to associate that with what you're eating versus where you are or what you're doing. And so the person then ends up becoming sick whenever presented with like a cherry popsicle in the future versus being un unwantingly sick just when showing up at the hospital. This would be something you would do with the patient's permission, but it's a favorable outcome, and most patients would much rather just be able to swear off orange popsicles and be able to go to the hospital without vomiting. So that's another kind of interesting approach with psychological origins that's ultimately very simple and is regularly done by folks on chemo floors. All right, so that is all that I have for you guys relating to cancer. Thanks for joining me.